Ms. Gray, I'm going to take you up on your offer. I'm going to come visit. Sometimes I think that we forget that drug addiction has no boundaries. And I want to thank you for, all of you, for what you're doing. And I want to thank you in particular because I know it must be very difficult trying to address this problem with very limited resources. A lot of people will say that you don't, I think a lot of people have gotten to the point where they become kind of cynical, Dr. Bailey, about drug treatment. They've seen people relapse, and so then they combine it with it's a moral failing, and they say it's their fault. And so how do we deal with that? Because, you know, one of the things that up here in Congress, the first thing you'll hear is, you know, let's not throw any money. We're going to be wasting money. When they may not say it like that, but that's basically what the result is. So how do we deal with that? You follow what I'm saying? Because in other words, how do we guarantee as best we can something that works? And Dr. Olson, any of you all may chime in. I kind of, when we were putting together the CARE Act, we tried to take all of that into consideration, but I'd like to just hear your viewpoint.
Thank you, Mr. Chairman. The stigma around substance use disorder is pervasive in our society, and I think all of us need to reset our thinking that it's not a moral failing. Substance use, opioid use disorder is a brain disorder. It is a disease that requires treatment. Unfortunately, it's a disease that features frequent relapses. And the treatment aspect of it is very, very difficult, but it can be successful. And I think that the more success that society sees, the less we'll have to deal with the stigma and the judgment surrounding the treatment.
I think one of you all said, and remind me who it was, said that when people do get treatment, and I've seen this research, that they have less problem, they're able to keep a job, they're able, who talked about that? Dr. Olson, would you talk about that?
Absolutely. So thank you for the question. And you know, we have a long history in this country of misunderstanding around addiction and what addiction is and what it's not. And you are absolutely correct that it is not a moral failing. Over the past 50 years, we have really developed our understanding of addiction as a chronic brain disease that is complicated. It involves interactions between genetics, so 40 to 60% of the risk of developing a substance use disorder is genetically based. It also involves interactions between our environments. So there was mention of the adverse childhood experiences. So early childhood trauma increases the risk of developing a substance use disorder. In any one individual, it's not entirely clear to what extent the genetics versus the environment and other psychiatric conditions that also increase the risk. Exactly how do those all play in together to have some people develop an addiction while other people don't? And the stigma around what this is and what it's not is still very profound. But what we know through decades of research is that medications, treatment, particularly when we're talking about an opiate use disorder, that medications such as methadone, buprenorphine, and injectable naltrexone reduce crime, increase employment, reduce the risk of HIV and hepatitis C transmission by 6-fold, and improve quality of life. And I think particularly now with the number of overdoses that we're seeing, it reduces mortality. In fact, there's a study from Baltimore City that looked at the expansion of access to buprenorphine and methadone treatment several years ago that found that it reduced the overdose from heroin-related deaths by over 50%, between 50 and 75%. So we know what to do. We know that this works.
Do all of you agree that the majority of Americans who have a disorder are not getting the treatment that they need? Anybody disagree with that?
No.
Do you agree that the federal government, including both Congress and the executive branch, could be doing more to address this generational public health crisis? Anybody disagree? And third, do you agree that we need a comprehensive federal approach to expand access to treatment and wraparound services, the kind of approach that's laid out in the CARE Act? All of you all agree? Dr. Young?
I would say for most things, it's a federal, state, and local partnership. I mean, states and local government play a role in most public policy, and particularly when it comes to health care delivery and social service delivery. So I would hope that Congress would be seeking help from NGA and NCSL. Most grant programs, it takes the partnership at the state level to ensure sustainability. So I'm sort of making an assumption that the Congress has already sought their advice in this, and I'm hopeful that partnership could be made, so that it is all three, state and local and federal government.
I want to just ask you, Ms. Gray, we have a situation where I think you and others mentioned children and how children are affected. A lot of times we don't see the impact on its surface. I mean, we think about the drug-addicted adult.
But they were children, and they started when they were children.
Yeah, and so what impact do you see on their children? You follow what I'm saying?
Yes.
And somebody else might want to address that too.
Go ahead.
I would just say, I think we sometimes forget about the effects of the families of that member, including the children. So when we talk about getting that money and getting to the local areas so you don't have to go through the state and Medicaid red tape, when we talk about that, some of the things that those the substance users have to deal with is time off work. It's child care. And again, that's where the child is affected. It's just such a huge array of things that is needed in that treatment. And so children are affected in that respect too.
You know, when we talk about wraparound services, we had Elizabeth Warren in my district, and we were talking about the CARE Act, and we had all these experts to come in, and they were talking about the kinds of things that you're talking about today. And then at the end of the session, a gentleman got up and he says, you know, he says, I've got a drug problem. He said, I'm 62 years old. And he said, all those programs are nice, all that stuff you're talking is nice. But he asked this question, and it really made me think. He said, how am I going to get there?
Transportation.
He said, how am I going to get there?
Exactly.
Yeah.
I mean, and it's would you please turn cell phones off, please? He asked the question, how am I going to get there? In other words, I'm going back to these wraparound services. I mean, and I guess that's one of the good things about the flexibility of the CARE Act.
Could I speak to that?
Yes.
I think that is a critical point. You know, it's really clear that, as I said in my testimony, that substance use disorders are very complex. They affect a lot of parts of people's lives. They affect their ability to hold employment. Most of the people who are at the late stages of their addictions have lost not only their family, they've lost their job, they've lost their housing. And the basic things that people need in order to live are just as important, and in fact, sometimes more important than the treatments that we can give them. There are many people that I've seen who we've provided treatment after treatment, but what has really helped them is to get into stable housing, for example. When I was in Connecticut, and the commissioner in Connecticut, we had a program called the Basic Needs Program. So we were providing treatment services for people. But what made the difference in terms of people being able to engage in long-term recovery were things like giving people money so that they could get a haircut so they could go and do a job interview, helping people to get from point A to point B, giving people small grants so that they could start a business, so that they could take care of themselves and they wouldn't be dependent on state aid. Those small things can make a tremendous difference, and it's one of the reasons why I think as we talk about this issue, we can't simply talk about evidence-based treatments. We have to talk about the whole range of services that people need.
Thank you very much. I'm going to have to let me go to Mr. Higgins, but I wanted to just throw out a series of questions as I did, and you may want to, in answering other people's questions, you may want to chime in and bring it up. But I want to get to Mr. Higgins now. Mr. Higgins.